Hi, my name is Paul Chous, and I'm an optometrist in Tacoma, Washington. I have a practice there across the street from a large endocrinology clinic, and my practice emphasizes the care of patients with diabetes as well as diabetes education. It's a really personal subject for me because I was diagnosed with type 1 diabetes when I was 5 years old. So I've had it for 45 years now. And I almost lost my vision to proliferative diabetic retinopathy in my early 20s, in my senior year in college. I had a big brother who was an optometry student at the time and examined my eyes and told me that I needed to see a retina specialist right away. And I resisted, of course, because it was my big brother. What does he know? But eventually he twisted my arm enough. I saw the retina specialist, and he told me I needed immediate laser treatment to save my vision, and that it was a good thing that I had listened to my big brother. So I learned my lesson that day. So diabetes really is what I do on a day-to-day basis, and it has a lot of effects on the eyes and visual function, many or most of which optometrists are going to be quite familiar with. If a patient has diabetes that's undiagnosed, there are several things that may arise in the course of an eye examination. One is, of course, diabetic retinopathy. As it turns out, people that have what's called prediabetes, this is a condition characterized by blood glucose levels that are above normal but haven't quite reached the level high enough to be categorized as having diabetes. Those folks, there's about 80 million of them now in the United States, that as many as 10% of those patients already have diabetic retinopathy. So we can pick up on undiagnosed cases of diabetes by doing a good comprehensive dilated eye examination on all of our patients. Another common finding that I see in my patients with undiagnosed diabetes is changes in their refractive error. And this is something that every eye care practitioner is familiar with. And quite a bit of research showing that it's a common phenomenon. Prescriptions can become more farsighted or more nearsighted. Research actually says that it typically sways more towards the nearsighted aspect, and that as blood glucose levels improve, it drifts back towards more farsightedness. But optometrists seeing patients that have huge refractive fluctuations, the first thing that should come to mind is the possibility of undiagnosed diabetes. Another common finding is premature cataract formation. We know that people with diabetes develop cataracts at a much younger age. Particularly posterior subcapsular cataracts, if you see that forming in somebody who's less than 50 years of age, I assume it's either diabetes or corticosteroid usage right off the top of the list. So glaucoma, there's some controversy about whether or not diabetes actually increases the risk of glaucoma, and really it depends on the particular type of glaucoma. We know that patients with diabetes have a much higher risk of neovascular glaucoma and of iatrogenic glaucoma caused by steroid treatments for diabetic retinopathy. Primary open-angle glaucoma, some reports say that there is a higher rate of glaucoma diagnosis in patients with diabetes, but of course there's the possibility of detection bias, which means these are patients being examined all the time, so you're more likely to diagnose everything in a patient that you're examining all the time, just as a function of dilating their eyes and looking very closely. So some other common entities that we see in patients with diabetes more frequently is dry eye. Glucose from high blood sugar actually gets into the tear film of the eye and osmotically draws fluid off the eye. The glucose also sticks to the cells in the cornea and weakens their attachment. So we see things like recurrent corneal erosion syndrome more frequently in patients that have diabetes. Other common findings are of the eyelids because there's a lot of glucose in the meibomian secretions. Glucose is food for bacteria, and so it's common to see patients having staphylococcal lid disease. Internal and external hordeoli are more common in patients that have diabetes. All of us eye care providers are familiar with cranial neuropathy as a function of diabetes. Diabetes causes infarction of the small fibers that serve the cranial nerves, and so it's not uncommon to have patients coming in with double vision as a result of their disease process. What I found is interesting in my own practice is that a lot of patients that have cranial nerve palsies as a result of their diabetes are relatively asymptomatic because it only happens when they look into extreme fields of gaze, extremely up or extremely down, and oftentimes they're not really clinically evident unless you really check a patient's ocular motilities thoroughly. You know, diabetes is just one of a number of health conditions that can be often detected by doing a comprehensive eye examination. Diabetes is the one that I see all the time, but even probably more prevalent is hypertension. Patients with hypertension get changes to the small blood vessels of the eye. And sometimes, you know, hypertension and diabetes, in fact, often commingle with one another. So sometimes in a patient that has diabetes and high blood pressure, it's hard to ascertain with certainty which process is leading to the retinal changes that we see. But we do know that high blood pressure accelerates the progression of diabetic retinopathy. A number of other diseases, as we all know, are much more commonly encountered in eye exams, perhaps than they would be in other arenas. Things like, you know, multiple sclerosis, other, you know, cranial or neurological manifestations that show up in the eyes. So really, optometrists and ophthalmologists were both on the front lines against the diabetes epidemic. You know, currently there's about 26 million Americans with diabetes. About 7 million of those folks don't know they have it yet. They haven't been diagnosed. And so there's a you know, increasing prevalence of diabetes every year in the United States and throughout most of the industrialized Western world. In addition, this additional group of folks that are now labeled as having prediabetes, about 80 million, we know the majority of those patients are going to go on and be ultimately diagnosed with diabetes at some point in time. And we know that the earlier diabetes is detected, diagnosed, and treated appropriately, the better outcomes for patients are, because we, you know, the statistics say that upwards of 20% of people with type 2 diabetes, when they're diagnosed, already have diabetic retinopathy. And this is something that I see on a daily basis. I see patients that come in telling me, I was just diagnosed by my primary care physician with diabetes, and he recommended I have an eye examination. Well, you dilate the eyes and you see retinal changes that are consistent with long-standing diabetes. And this is why it's so critical to catch diabetes as early as possible. And optometrists and ophthalmologists both can play a really critical role in making that possible. So there are a variety of technologies beneficial for ocular diagnosis. You know, we all of us on a daily basis use things like fundus cameras and optical coherence tomography. A new device that I'm interested in is received FDA clearance, and it actually measures long-term glucose buildup within the crystalline lens of the eye. And so the preliminary research with this device shows that it can actually pick up on undetected levels of high glucose years before standard blood glucose testing reveals a problem. So this is something that I'm excited about. I'm involved as an advisor to this particular company. One question that's frequently brought to me by my patients is, you know, why do you want to know about my systemic health? I'm here for an eye examination. Why do you care about what medications I'm taking and what other medical conditions I have? And I understand if you're not an eye care provider, you know, you're not maybe educated on the connection between eye health and systemic health. But in fact, a lot of medical conditions have manifestations in the eyes, and I talked a little bit about some of those. It's important for eye care providers to look for these conditions because, in fact, a lot of patients aren't receiving regular primary care. And so the eye doctor often is the only healthcare provider that a lot of patients are seeing. So we can step in and have a profound impact not only on their vision, but their systemic health and their long-term ability to lead a happy and productive life.